Eureka, we have it? Yes. Okay. Today Meta has agreed, but just to be on the safe side, I'm gonna record it so that we have both of them. Oh, thank you. Joining from Ukraine, Nyathioma utatuona tu kando because you need to tell us about this Ukraine story vizuri, lakini karibu. Yes, and today I've been a nice teacher. Just type and tell us where you got you're joining us from and where you got this flyer from. It's just for my own statistics and my brain. But welcome. Good morning, the people on this side of the oceans. Good morning, good evening, and good afternoon, the people on the other sides of the oceans. Today is part 2 of the discussion on ADHD. We started we started 2 weeks ago. I know in between we did disaster management. Only us. We are the only people who come from ADHD and then manage disasters. But this week we are gonna discuss the management of ADHD. So as is our usual, we are gonna start the Saya will open the Kiwanja by just giving us his spiel. Saya, uwanja ni wako.
Thanks. And from whichever side of the ocean you're joining, we are honored with your presence. And from whichever side of the ocean you will watch the video and whichever platform, you are the reason we put this material out there. So thank you. One of my friends used to say, if we're having a conversation that we do not intend to do something about, then that time is wasted. If it makes the conversation either be gossip or just complain. And complaining is very low level. It's very easy. All it requires is eyes to observe, senses to consume, and then a mouth that is able to speak. And so many times when it comes to the question of ADHD, sadly, it has been treated with a form of we observe, we either gossip or we complain or restrain or beat or pray or do every other thing other than being helpful. Or worse still, we sideline or ostracize the person. They just are not included in stuff, or they become misbranded with things like this one is not reliable, or this one will not follow through, or this one is like this. So we do the easier human thing. We label and ship or file our way to whichever place. So when we label them as unreliable, we file them in the unreliable corner. When we label them as problematic, we file them away into the problematic corner, and we deal with them accordingly to where they have been posted to or shoved away. But recently I was going through some training, and it's interesting that the person training me on mental health, a professor, very well published, written like 8 books, not papers, like 8 books, admits that he has ADHD and that he has been able to find medication around that and been trained on how to then channel his moments of high energy into moments of extremely high productivity. And as a result, not only is he a psychologist and trainer, but he's also been able to put out many books out there. He doesn't or didn't look like he's struggling for means at the end of the day. So rather than ADHD being a death sentence or being the postage stamp that we put on individuals and file them away to some place, or rather than ADHD become the gateway that opens an individual to be exploited because they have bouts of energy and all they can do is either dig or do something for protracted times. What if we were able to find ways to either treat or ways to better manage it, and then channel this energy and lead people back to the path of recovery, and while they're on that path and eventually when they get to the full destination, be able to be optimal individuals? And funny enough, because this is a talk about ADHD, we want to keep it short and simple that way. Back to you in studio.
Okay, thank you, thank you. So Lambert, because I'm not seeing you, Lambert and Nema, smoke signals, everything. Can the two of you just recap what ADHD is and what it's not? Just in the next 2 minutes.
Okay, I can start. I think I've just seen Lambert coming in. So good evening and good morning and good afternoon. So what is ADHD? ADHD is attention deficit, easy distractibility, with or without hyperactivity and or impulsivity. So what that means is these people it's not necessarily that they lack attention, it's just that they focus on so many things at the same time. So you find the task at hand being deficient of the attention that it needs. So they end up shifting from one task to another, moving from one side of the room to another, because of lack of attention. And hyperactivity is, of course, that hyperactivity itself. And then impulsivity is now they don't really process things and they don't think about things before they actually embark on doing them. So you find a child just comes in, hops on a table and jumps without really thinking, okay, will I get hurt? Can I, is there another way of doing this? They'll just jump because it feels nice to jump. So that's what ADHD is. So the presentation can either be majorly a child or a person may be majorly inattentive. That means the hyperactivity is not as much, but for them, attention is the one that is really the strong factor in the ADHD. There are those who they're okay with attention, but they are constantly hyperactive. And then there are those ones who have both. So they have a combined inattentiveness and hyperactivity and or impulsivity. So in summary, that's what is. And then we went ahead and discussed what exactly does that look like in a child. So this is a child who constantly be fidgeting, who will constantly be absent-minded, quote unquote, in class. You may be talking to them and you are not sure, did they hear you? Can they understand you? Because even following instructions is a challenge. You find these are children who will have very difficulty in organizing very simple tasks like, after school you have to do 1, 2, 3. For them that becomes a task. They are also very forgetful in some daily chores that they're expected to be doing based on their age. And then of course that's just lack of listening and them losing things. So that's what inattention will look like. And then for hyperactivity is the constant fidgeting, moving around, constant in motion. And I think Lambert said they are, the motor part is like Ferrari. The brain is like Ferrari, but the brakes are of a bicycle. So they are constantly in motion, moving from one end of the room to the next. They can't sit still, cannot play quietly, keep on running around, climbing on things. You just continue telling them, stop this, and then they go do something else, stop this, and they go do something else. So that's what hyperactivity is. And impulsivity is that just them just doing things dangerously without really thinking of what that means. And because of that, you find these kids are mostly prone to accidents. They're mostly prone to even accidental poisoning. These are the kids who you'll be brought into the A&E and they'll have drunk, a liter of bleach or a liter of a cleaning agent simply because they were thirsty and they found it clear like water and they drank it just to realize, oh, actually it's not water. It's not what they thought it was. So I think just to start off, that's what I can say. I think Lambert can take it on from there.
Good evening.
Good evening, Lambert.
You can all hear me. Oh, thank God, like my video has a problem. Thank you very much, Emma, Dr. Emma. Anything else to add? You've done a fantastic job. You've presented well. The only thing I might want to add is that analogy of a bicycle with, a Ferrari with the brakes of a bicycle, are not my words. They are words of Dr. Very that describe ADHD from childhood, adolescence, and adulthood. And you might want to check out some of the books to understand better about ADHD. That is Driven to Distraction is one of the books. And the second book is Delivered from Distraction. Their latest book is ADHD 2.0. That's the 3 books that they have written that I to understand more about subject matter. Thank you.
Okay, Lambert, while we're at it, could you just even your audio is a bit choppy.
Oh, no.
Yeah, I don't know. Smama, do you
Okay,
have,
I might have to let me see whether I can use my something else, but just to sort out the audio. Yeah. So let me
okay,
sort
but
it.
right now it's flowing. I don't know what you have done. This Smama hapo.
Okay, sawa sawa. Unanisikia sasa?
Hapo nakusikia Smama hapo, and then yeah, please kindly text the books to Immaculate.
Okay,
Yeah,
not
yeah.
a problem.
Okay, so then let's manage ADHD. Sorry, our teacher today is Kenya Power ya huku Kenya Power, so she may or may not join in, so we'll see. But let's just manage. So what are the steps? So once you've gotten the diagnosis of ADHD, what is the next step? Let's start with mtu tunajua sauti yake iko mzuri, Neema. Dr. Neema?
Okay, so after the diagnosis of ADHD, after the diagnosis of ADHD, one of the things that we usually do is rule out other things, because most of these neurodiversity conditions don't come in alone. So we have to rule out, look out for other conditions that may present with the same behavior challenges. So we are looking at of course, mental health, your mood disorders, anxiety, what are these other things called? It's called what? Damn. The one that for defiance.
ODD,
The one, yes, that
oppositional
one.
defense disorder. Yes, yeah.
Yes, yeah. You look for DD, of course. You look for autism, OCD. So that's the first next step. Like look for other comorbidities that could coexist with ADHD. And then the second thing is rule out other organic conditions. So you have to go do a series of tests. That means in hospital, yeah. Confirm that you like the brain is okay, because sometimes some seizures present with those hyperactivity and lack of attention. So you have to rule out those ones as well by doing either imaging or EEGs, just to rule out that. And also now learning challenges as well, you may need to rule out that, especially for school going children, because those things really come in together, like they are always together. So after that, now you've confirmed that, okay, actually this one only has ADHD and nothing else. Then usually when it comes to therapy, there are usually 2 arms. The first one is the behavior, managing the behavior, which is now the psychotherapy. And then now the other arm is now the actual medication. For children, we really try to go for the behavior modifications more, as compared to having medication started on early. But of course, it depends on the severity of the ADHD. So we have some medicine that we usually give, and they're usually psychostimulants, just to calm the babies. But of course, it being a long-term condition, we usually just like start off for those cases that are very, very severe, because it's true, some kids cannot be still, cannot be still. You find even sleep becomes a problem. Like literally every aspect of the quality of the life of the child, the quality of the life of the caregiver is affected. So you find you just want to calm them down a bit as you do the behavioral interventions. So I think I'll leave Lambert to tackle the behavioral intervention.
Okay, Nema, thank you very much. I hope you can now hear me.
Yes, I can.
I think during the process of maybe ruling out any other conditions that other that you described very well, I think one important thing to discuss, and which is extremely important in society today, is whether to medicate or not to medicate. And you find many people reach out and say, no, I'm very reluctant about medication. I mean, this is just a child. It might affect their growth and development. I mean, what about the side effects? What about diet? And I think that's a very important subject in this very century that we are living in, because we also have witnessed and we've seen that some children, if the diet, some of these symptoms are managed very well. So the point I'm making is no one shoe size fits all. It is extremely important to do the screening assessment, rule out any other problems that might mimic ADHD, identify other problems that come along with ADHD, and come with a treatment plan or therapy plan that will involve a multidisciplinary team. And by this, I mean there is the pediatrician, doctor, there is a psychiatrist who might need to put the child on treatment. There could also be a neurologist, because some of these children might even have seizures and other neurological related problems. You might also need a physician or dietitian. You might need a sports professional to also help in engaging these children in activities that will perhaps make them manage issues maybe to do with possibly weight problems and so forth and so on. Already I'm now starting to talk about how then all this, when put together, the behavioral process starts, the behavioral program starts falling in place. And once you now even do all that, what is extremely important is to now sit with your client or patient and understand their narrative. One of the challenges we have is we are called in our society daktari. Anyone who manages a patient or a client is called daktari in our society. So those ones from the West, you will just have to understand if someone calls me daktari, DR, even if I'm not a medical doctor or a PhD holder, because it is a cultural thing. And you find then the assumption is that the doctor has all the answers. And because I've come to you, you have the magic bullet. So I will listen to everything that you say. Jump how high, and I'll do. Treatment or behavioral program involves the child or the adult and the family or any other persons dealing with them. So if the person lives with a minder or caretaker, involve them. If a person goes to school and they are teachers, we involve them. We send them even questionnaires to really understand their context and what could be the symptoms or the problems that this child is facing. All this is in keeping with coming up with an evidence-based program that will meet the client's needs. Because people with ADHD, if you don't listen to their story, then that's the beginning of losing them. And losing them by this, I mean, you might actually think that you're moving the right direction, helping this person, because they don't feel part of the program. So incorporating them in this process is extremely important in coming up with a behavioral modification or behavioral program, which I believe we can talk more about it. So that's just an introduction.
Thank you. I'm just wondering on the medication side, Dr. Nema, you mentioned stimulants. I know we use stimulants, but just explain to the layman side of my head, which exists. Why are we stimulating these already hyper-focused, hyperactive people? What's the thinking behind using stimulants for ADHD as part of ADHD medication? Dr. Nema, are you there? Okay, Lambert,
Okay.
no Safari
All right. All
Community.
right.
Okay,
All right.
Lambert, are you able to
All
pick
right.
that? Yeah.
Yes, yes. Now, the most common medications that are used in our country, stimulants, is one of the very old medication. I think it's been there for over 60 years, called Ritalin. And Ritalin, the other medication, which stays in the system for a short time, which I think about 12, 6, 7, 8 or so hours, and then it gets out of the system. And then there is now a Concerta, Concert with an A. Now it's the same chemical component, but it's slow releasing. You take it once a day, but with Ritalin you take it 3 times a day. Now, when coming back to your question, when we talk about ADHD, the frontal part of the brain, what is responsible for executive functioning, what is responsible, by this I mean planning, organizing yourself, remembering stuff, and so forth and so on, is understimulated. A good analogy would be, take 2 cups. One is filled with water and another one is filled halfway. Now, that is filled halfway is the brain of someone who's ADHD. So the stimulant stimulates, it adds water, or the chemical that is added to that cup of water, and it's filled, is what then now is called the stimulant. It stimulates those parts of the brain that are responsible for executive functioning, so that you can concentrate throughout the day, so that you can listen through and follow instructions, so that you are not easily distracted and start listening to noises that are coming from outside. Maybe kids are playing and your mind wanders and start thinking about when is a break going to come. Your brain now is able to focus on what is happening in that particular room. That is what stimulants do, not what you'd think that, yes, it stimulates you to a point where now you become even more hyper. You see, that is what could be confusing. No, it just fills up that kikombe or that mug so that you can be able to be in the present moment and focus.
So while we are still at that point, so what's the difference between an ADHD brain taking the stimulant and a non-ADHD, or I know we are not supposed to say a normal brain taking the stimulant?
The answer is simple, and that is why sometimes we keep, and not sometimes, we always insist. After an assessment, you will find the high likelihood is that if someone has ADHD, the medication will work. The opposite is also very true. However, we also have to now, and this is not my area of expertise, you find that there are some individuals who, when they are given medication, does not for some reason work, even if they are ADHD. And that is where now the professionals, the psychiatrists, and other medical professionals think or start asking themselves about options. Sometimes you might find someone has ADHD, but when they come to us, the biggest problem is not the ADHD symptoms. It's, for example, depression. So the professionals might decide, let's treat the depression, and the ADHD is managed. So you don't have to give them a stimulant to manage the ADHD. And that is just like trying to demonstrate to all of us how these conditions can be complex. And that's why understanding someone's story, even if they say, or even if you pick ADHD, you need to ask yourself, from what we are picking, what is the best line of treatment? Instead of just saying, yes, you're ADHD, and we just manage it. We always have to really take time and understand which will be the most beneficial mode of treatment for this person. There are people who also would present and they don't need medication. And last week, but one, we said most of this needs a lot of education. With the education and the information, then you are able to decide whether to treat using medication or not to treat using medication, but instead to educate and come up with a tailor-made program that will meet these individuals' needs.
Thank you. Nema, testing, 1, 2. Are you there? Are you back? Okay, I can't see Dr. Nema. Okay, then let's move to so in terms of if we have a dream team, like I have Jeff Bezos kind of money, and and I need to manage ADHD, what's the ideal dream team, Dr. Lambert? You're gonna be Dr. Lambert.
That's an extremely good question. Now, first of all, we do not have, and I don't think whether it's anywhere else, we don't have a proper system or criteria or system that says this is how we are supposed to assess and screen and whatever ADHD. So perhaps coming up with a protocol, a standard protocol, would be the first step, whereby we also ensure that these people who are coming up with a protocol are able then now to come up with a system that involves people at the primary care level. Because when you go to hospitals, whatever, in Kawangware, in Western Kenya, and so forth and so on, you find most of those people might actually be willing to help, but they are clueless about the ADHD. So it will be very helpful if these people are empowered at the primary care level so that they are taught or skills of actually picking ADHD, and then having a very clear referral system where specialists are involved. But you see, specialists are few. Now then we need to build capacity on other professionals. How many graduates graduate from university who have done psychology? There are so many. We are receiving more and more young people. Those young people can do an extremely excellent job in our communities to be able then to make use of such kind of money to ensure that no individual is left behind when it comes to, first of all, ruling out ADHD, and secondly, managing it. And last but not least, having programs that focus on prevention. And prevention, I would mean not prevent ADHD because it's already there, but sensitizing people on how you can prevent this thing morphing into other complications. Because even as we saw last week, but one, that if not managed early, this condition can morph into trauma-related problems because people with ADHD are predisposed to being traumatic. You are very nice and kind and welcoming and loving, and people can actually, unfortunately, take advantage of you. And the shame and the guilt might make you not to talk about anything. So imagine you already have ADHD, now you have trauma that you're not talking about. That might lead to anxiety. Then now that leads to substance-related problems. So starting from the lowest level at the cradle makes a lot of sense. This month has been Mental Health Awareness Month. I cannot leave mothers behind. Prenatal, during that time, and the fathers, of course, we keep insisting fathers should also be involved, because not because they should per se, but they're already involved. Many of the fathers are willing to be involved, involve them and also educating them, so that even a mother can know, huyu mtoto wangu, they are unusually very quiet. Could it be inattentive symptoms, perhaps? Or this child is always kicking. Could it be that this child is hyper? So that at that very early stage, we actually have a way of mapping and following up these young people and knowing that this child was born at this hospital, and at age 3 or 4, we are starting to see some neurodivergent kind of features. We are starting to see some symptoms of ADHD, so that there's early intervention. I can go on and on and on, but I hope and believe that if, like you've said, you are to be supported by a lot of money, then those are some of the ideas or the things that we might want to immediately focus on. First things, protocol. If we have a protocol that makes us speak the same language, then definitely we will go a long way in ensuring that we do a lot of stuff to help this generation and the future generation.
So while we are still playing catch up in training people, we really need to empower the people who actually carry the nation, the clinical officers and nurses in primary care in Kenya, yeah, because they're the ones who get to people, do the antenatal clinics. They're the ones who are covering our outpatient departments in a majority of the country. Please support doctors. I'm over here, of course, putting my MBCHB hat on. Sharon Tokelezea. Because I'm going to throw you under the bus because your ADHD was discovered much later. Yeah. And yeah, just give us a brief of your story. I know I've put you in the same category as you're supposed to be in my brain. Give us a brief of your story and how they landed, the diagnosis was landed and what they're doing for you.
Okay, so I'm looking at the time so that I don't go on for an hour.
Okay, let's put you on the clock. Most at 7 minutes.
Oh, that's doable. Okay, fine.
Okay.
So I got diagnosed with ADHD officially in was it December of 2022? I had been in Germany at the start of October. So October 1st, I had landed in Germany and we were smack in the middle of winter. So I started to notice I had symptoms of depression earlier when I was in Kenya for about 6 months, if not longer, but trouble sleeping, staying up all night, just being sad all the time, crying a lot, lost my appetite completely. Of course, started to lose weight, and I'm already a small person, so more weight was lost. And I was staying with my grandmother at the time. And she told me, you're depressed. I was like, yeah, I know. I don't know what to do about it. So when I came to Germany, I thought, oh, I think I'll be better. I'll be focusing on school. So, but then I got worse. I had gotten in touch with a Kenyan psychologist from Jipende Wellness. And so I just called her and I told her, as I had foreseen, I'm going to need therapy because one day I had been, I think in the course of that week, I'd been staying up all night and then falling asleep from 5 a.m. So I get into bed at midnight, I get to bed at 1, and my type of ADHD is I don't sit still. I get everything done. If you live with me, your house will be perfectly clean every single day. Of course, at the expense of my back and my hands, because sometimes I clean to a point where my skin comes off. So, which also led me to be diagnosed with OCD. But the long and short is I couldn't get out of bed, and I'd been thinking about getting out of bed from 7 a.m. And so I eventually called my therapist, Ruby, and I told her I am, and I was laughing. I was like, I don't know why I can't get out of bed. I need to be in school at 12 noon. And she told me I had a depressive episode, which my inner African was like, no, I am a strong Black woman. I can't have a depressive episode after I have come to the abroad. You know, life is better than it was in Kenya. But she helped me. I think one of the most empowering things anyone has ever said to me, because this was my second round of therapy, was, I'm not going to ask you to change your brain. I'm going to teach you how to use it the way it is. And that was very empowering because for once, someone was not telling me I was broken. Someone was not telling me that I was weird. They were telling me, your brain is as beautiful as it's supposed to be. Let's now just figure out how to use it as it is. Yeah, so there was that. I don't know how much time I still have left. Leading up to that, okay, good. Thank you. 4 minutes. So leading up to that, I remember, and this I uncovered in therapy, I had always been the child who was called slow, careless, and forgetful, exactly what Lambert and Nema have been talking about from the last time we had a session. I would lose everything. My socks, I would remove them and I would not remember for the life of me where I'd put them. I used to lose all my school uniform, either because I left it on the hanging lines for too long. What else? I was hyperactive. My mother had noticed I couldn't sit still. I always had to be cleaning, doing, fixing. And I started this as a child. I was a parentified child as well. So just always organized, always more mature than the other children in the room, always daydreaming in class. So I used to do very poorly in math and very well in the languages. And I'm still very good at languages. And all that. So in hindsight, all the signs were there, but no one knew about ADHD, at least not in my family. And imagine I was raised in Nairobi and my grandfather went to London to study. So imagine with all that knowledge in the family, there still wasn't anyone who could pick on this as ADHD. But that's just the long and short of it.
Okay, I'm just confirming Lambert and Nema. We are slapping the people of Safaricom or whoever your provider is. Lambert and Nema, are you back?
Neema is back.
Okay, hallelujah. Praise God.
Sorry.
Okay.
Sorry.
So we've touched on medication. Lambert has talked about his dream team, and with emphasis on primary care, which I support, because the people who actually carry a majority of the patients in Kenya are clinical officers and nurses, whether we like it or not. And so we need to empower them. And then Sharon was just giving us a brief history about her lived experience as someone who was diagnosed as having ADHD in adulthood. So what she said, and I want us to pick it from there, she was told her brain is beautiful, but she was given tools to work with that beautiful brain. So tell us about these tools of working with these beautiful ADHD brains.
Okay, so these tools are actually developed and they are usually customized based on the needs that this child or this client or this adult has. And so when you look at ADHD, generally, their challenges is in attention and concentration, the restlessness and impulsivity, poor organization and planning, forgetfulness, memory difficulties. Like those are the major things. But I think if you can recall what Lambert has said, every person is different. So yes, this person has ADHD, but really, what are your challenges? So that is the question, and it's usually from the answers of that question, you now develop tools that will help this person based on their challenges. Now, generally, looking at, for example, if the issue is attention and concentration, so we are looking at when you're giving this person instructions, how are you giving the instructions? So usually people learn through visual, auditory, some do it practically. So you have to know, okay, this, as she said, this person, for example, for her, daydreaming and so mathematics was also difficult for her. So most likely for her, it's more auditory. She could hear and maybe she could practically read and now be able to understand. And I think that's why language becomes easy for her. Maybe also with writing, that also would help. So when you're giving instruction to this person, can you write? Instead of you telling, for example, you telling, like maybe it's your daughter or your son, when you wake up, I want you to do 1, 2, 3, 4. Can you write these instructions? And is it possible you also put timers? Because again, you see, organization, for them to be able to organize themselves to be able to do that can also be a challenge. So can you put on timer, or can you do a schedule that has visual, like from this to this time you do this, and then from this to this time you do this? So the whole idea is to be able to incorporate the challenges and the strengths together, so that at the end of the day, they are able to actually do what they're supposed to do when they're supposed to do. So when you look at time management, because that's part of organization, how are you going to make sure that this child keeps time in, for example, in class, for instance? Is there a way you can have a plan for this person? Can you have a plan for this person? And most of the time, they prefer plans that are fixed, so that it's also fixed in their mind. Can you again set alarms? Can you have some form of reminders? Which tasks are the most important tasks that they need to start with? Which other tasks can they do maybe later in the day, or maybe they can even push it? For example, if you have exams and you know your next exam is a math exam, you should put a reminder to tell you from 8 a.m. to maybe 9 or 10, you should be doing maths, okay? Because if you're going to leave it open and expect them to just figure out because maths exam is coming in, they won't. More chances are they're going to do something that usually has more dopamine for their brain. So they're most likely going to do something that they love more, and it's easy for them more as compared to what is actually needed, because that's one of their challenges again. Okay, for the aspect of distractions, just minimize distractions. And you see, distractions means different things for different people. There are people, okay, I didn't hear her story, but there are people, especially for those who have the ADHD, they cannot sit in a silent room. Like for them, silence is actually a distraction. Yeah, so they want some white noise in the background for them to be able to work. They want some soft music for them to be able to work. Yeah, so when they have to do a lot of work, and this work needs a lot of input from their mental place, you have to understand what works best for them. Is it the white noise? Is it total silence? Is it some soft background music? And whatever it is that works for them, then that's what they should be giving. Now, of course, in schools, that can be a challenge. And that's why sometimes we advise, like now schools and of course teachers, is it possible these kids can be allowed with, for example, when they are doing their preps in the evening, when it's self-study, can they be given some earphones that have some, white noise, so that they are able to actually sit still and be able to concentrate and perform tasks? Okay. And then the soft skills. Now, the soft skills, when we talk of such things, how do they relate? Because one of the challenges is, them jumping. Like you are having a conversation, they come and they just, they just join in. They don't know how to, give space to the next person first, and then they finish, and then it's my turn to talk, because they'll just jump in. So those are skills that they have to be trained. Like, once I'm done talking, I'll give you an opportunity to talk. When you and it's the same thing that we also train children who are on the spectrum. Like when someone is talking, you don't talk. When it's your turn to talk, maybe somebody can call their name, or somebody can tap them, or before they talk at any point in time, raise up your hand. And I remember I was in we had a conference, by the way, and they told us one of the reasons that Zoom actually, was it Zoom or Google Meet, they had a raised hand, is because of inclusivity. Because some of them, they'll, like right now we are talking, someone will just unmute and start talking. And they are not doing it because it's arrogant. It's because they feel like, okay, I know this and I want to say it. So that also happens in schools. So can we teach them, before you talk, raise up your hand, or before you talk, somebody calls out their name, because then they know they have that. So otherwise they'll not talk unless they are given a chance to talk. So basically what I'm saying is, you look at the challenges that this person has, and then you try to customize ways. And of course, this is a teamwork. Like Lambert had said, it's a teamwork. How best can we make your life easier? The purpose is not to change you. The purpose is to be able to use what we have, so that you are able to adopt better in the environment and in circumstances that we are in. Yeah.
Okay, thank you. Lambert, are you there?
Yes, I'm back. I lost you guys. I missed the story, unfortunately, so I'm just trying to catch up. Maybe at this point, I'll just add to what Dr. has said. I think the long and short of it, ADDers don't tell them, the best way to put it is that don't tell me what to do, show me how to do it. And that is where now the idea of really working with them and coming up with a framework that would actually make sense to this person. One thing I'd like to add is the importance of exercise. Exercise has shown that people with ADHD, exercise can help them actually really calm down and focus on things. So if you can incorporate that in the routine of a young adult or even a child, whereby if it's a child, you ensure that they have an opportunity to dispense their energies. That is as well exercise. For adults, if movement is important, if it's going to the gym, if it's walking every day at a specific time, because with ADHD, you need to get used to a certain routine because of the disorganization and being all over. Then once you come up with a program, a behavioral program that tailor-made to the needs of the person, then you work together with them. And in every subsequent session, you're able to review the program. But also you must make sure that you give them an opportunity to actually vent. Because sometimes one of the challenges we have as professionals is we want to be very robotic, like mwalimu. Mwalimu hiyo ni kazi yake, it's their job, because they give you a curriculum and you must stick to the curriculum. But on the other hand, if someone is ADHD and they come to your office, they might come very excited and they want to give you good news about one thing that seems very minute to you, but is extremely important because it will stimulate them and give them motivation. Because another way of looking at ADHD, it is merely a problem of motivation. So when you are actually following up in the routine in terms of consistency and making sure that they are sticking to a certain plan, it is always important in sessions to give them an opportunity by, for example, asking, how was your week? Are there any highlights? Is there anything exciting or extraordinary that happened to you? And you can imagine how someone will feel so excited that you've actually asked how their week has been. Because maybe they haven't done their homework and you're expecting them to come and present the homework that you had given them. So if you give them an opportunity and they say, yes, it was very, very challenging for me to actually implement this, then it's a win. And that is how then you start appreciating that the behavioral program is not just a piece of paper where you write down a timetable. It is an engagement. Asante sana.
Sharon, the ADHD, now that Nema has said that, it's never gonna leave my head. Okay, go ahead.
No, I can actually
For
confirm.
you, we have to always put a timer, right? Okay.
Yeah.
No. 7. Yeah.
So for me, it's actually true. Like, I can confirm everything that Nema and Lambert have just said, because and I'm saying this again, I keep sharing my lived experience because there's someone out there who will notice, wait, this is me, and finally get the help they need. So setting alarms is indeed important. And I'm going to talk about the nutrition part as part of the dream team. Nutritionists are also point of care, especially in maternal health. We're the ones talking to women about how to latch on their babies and how to breastfeed properly, sitting upright to make sure that, they protect their backs, etc. And sometimes when you're that close to someone, you're able to notice certain things. You're able to notice if, they're always fidgeting, certain repetitive movements that they can't help, or if they're doing something with their fingers. So there's usually a crossover between ADHD and autism. And also anxiety has some of those issues. We call it psychomotor agitation, where you keep making certain repetitive movements that you can't help. And pacing is one of them. If you're always pacing, usually the same distance, back and forth, if you notice someone doing that, if you notice them tapping a particular part of their body repetitively, those are some of the things I'm looking at when a child comes in for clinic days. If they're doing certain, they're kicking the back of a seat a certain way, if they're tapping a certain way over and over. And if the mother is also doing that, because that, you don't know whether that's ADHD, you don't know whether that's autism, you don't know whether that's anxiety, because psychomotor agitation presents in all three. And then other things I'd be listening for are, and it's when a woman is breastfeeding and she talks about the breastfeeding experience and she says she hates breastfeeding, because every time she feels her child nursing, she wants to, or she's grinding her teeth when she's breastfeeding, because you struggle with you can relate. And especially if they say, I'm not a touch person, I can't stand how much my baby is touching my face and touching me, or they get irritated because they're overtouched, meaning they're overstimulated. Also, I can say I am triggering you. Any woman who says, I can't stand anything, in fact, anything to do with the 5 senses, they're overstimulated by sound. And that could be because your baby cries a lot. God forbid if you have, if you have issues with sound, which presents in ADHD and autism. So if you're very sensitive to sound issues, if you're very sensitive to textures like cloth, there are certain cloths you can wear on certain days, but you feel like wool is itchy on your skin. I usually tell people, if you've noticed that, you need to be assessed further. If you're very particular about certain colors, certain things, yes, tags on clothes, there are people who have to rip off this tag because if it touches your skin, you feel like you're going to pull out your hair. Pulling out your hair is another one, and or hair falling out. So if I notice anyone who is repetitively tugging at their hair for some reason, and that also happens in pregnancy a lot because of hormonal changes. And I think our team of psychologists also needs to talk about the hormonal changes in pregnancy and in menopause, again, just to highlight it, and how that really, really messes with any spectrum issues. Now, to nutrition, very briefly, it's anyone who has what we call weird eating habits. And I use weird very loosely because that's a word we don't like. It already makes us feel different in a world where we know we are different. So whenever I hear someone say, so-and-so doesn't eat, they're a poor eater. They eat their food, they leave it halfway, they go away, they come back. And you can notice this all the way from childhood. So it could be that and especially if they say, my nanny tells me my child always has to be running around when they're eating. One, I would assess what they're eating. If you're feeding your child sugar and they already have a hyperactive issue, you're making their condition far worse. And that's true for ADHD and autism. So that's one thing I'd be looking out for. If you have a child who is louder than all the other children their age, they run, they jump, they bump into things a lot. Those are things I'd look out for. And for some of these kids, you remove soft drinks, you remove juice, you remove candy, and then you just feed them actual food like God intended for us to feed children. And fruit is not harmful in its natural form because it has fiber and blood glucose gets into the bloodstream, gradually, as opposed to if you're eating pure sugar or processed sugar. If you remove junk and then this child's behavior improves and they're paying more attention, if you replace juice with water, and I mean including freshly pressed juice. Juice is juice. It's all an overload of glucose and fructose. So we need to eat fruit, not drink it. Those are some of the things I'd be looking out for. So this is not just for children, it's also for adults. And yeah, these are some of the things we need to look out for.
We'll come back to you, the nutrition bit, because you umetuambia tu what to look out for, but as part of treatment, we need to talk about it. I just want to go back to the therapies. I know they've told us about the tools, but because people name drop these things out here, can you talk about DBT and CBT, Lambert and Nema? Or do you want to start?
No. Let them start, and then I'll just talk about how each of them is uniquely different depending on whether it's ADD, ADHD, autism, anxiety, etc.
Nema, Lambert.
I'll say let Lambert take that one.
Okay.
Thank you.
Lambert, uko juu ya mti?
All right, sawa. Mnanisikia sasa?
Nakusikia.
Okay. Now, sometimes CBT is close to my heart. And I think CBT maybe is under the umbrella of what we'll call the third wave therapies. And third wave therapies includes also DBT. So when you talk about CBT, it's very simple. It has a lot to do with is what you're thinking and how your thoughts affect your emotions. And as a result, this person has a negative attitude or this person has a positive attitude. So when you talk about CBT, the end result is that if you are having repetitive, irrational thoughts or patterns of negative thinking, then the result will be negative and vice versa. So CBT has really become a big thing because, for one, it has been there for many years. Sometimes people think it's very new because cognitive approach or theory started in the 60s, late, even much earlier. And then there came behaviorists. And now, with time, then the likes of what you call Dr. T. Beck's, the very big, he's the one who came up with the Institute of CBT. And CBT is favored a lot because it is evidence-based, it is specific, measurable, attainable within a period of time, and reliable, and actually, with time, you're able to see results within a very short period of time. Now, when it comes to DBT, it is also under the umbrella of the same, and it actually is now also under the umbrella of what you call acceptance and commitment therapy. So you see, all these are evidence-based approaches where you can come up with a plan that specifically focuses on managing someone's needs or problems. So DBT has things like strategies where you use concepts like mindfulness and what I've mentioned in terms of acceptance and commitment. And a lot of this has to do with ensuring that you become very conscious about yourself and the challenges that you're facing, and how then change as a result of accepting your situation or where you are at would actually then help you learn specific skills that will manage your regulation in your thoughts, your emotions, and your behavior. So the long and short of it is that at the end of the day, after an assessment, with the help of the therapist, you can decide which modality is best. You'll find that many a times after an assessment, we will pick a little bit from all this to come up with what I said, a tailor-made program that meets your individual needs. Therefore, these terminologies should not confuse you, especially if you go to the internet. This can only help you help the therapist or speak the same language as the therapist, but not to then dictate to the therapist perhaps what he should do, or maybe the therapist to insist that this is how we should go about it. It has to be teamwork at the end of the day. And of course, if any of these methods are not working, then you go back to the drawing board and realize perhaps the approach that you might have wanted to use, which I'm making it more interesting, is what you call psychodynamic approach, of which then becomes a story for another day.
Sharon, as a recipient, Tokelezem, one day I'll be serious, one day. Okay, just what I mean, you wanted to just speak to these third waves as a recipient of the same, if you have received.
I would say that I probably got cognitive CBT, cognitive behavioral therapy. Can you hear me with all that noise? Okay, yes. You can see how easily distracted we get. So anyways, I was a recipient of CBT because just by definition, I'm just going to ask Dr. Google, well, BetterHelp. It's talk therapy that helps you manage your problems by changing the way you think and behave. So what we basically addressed in therapy was, some core beliefs. What are some of the fundamental beliefs you have and how they affect the way you look at life, etc. And this was important because, again, as both Lambert and Dr. Nema have highlighted, the thing that caused me to pick a phone and call a therapist was not necessarily the ADHD, it was the depression. And so that was a door through which we were able to now discover, okay, let's do assessments for other things that co-occur with depression, typically anxiety. And then I also mentioned certain things that caused my therapist to realize, oh yes, she has social anxiety, she's struggling to leave the house and get things done. So those are the two things that, caused me to seek help. The depression, first of all, and the social anxiety, which made it hard to even leave the house to go, grocery shopping. And then, of course, now other things started to come up, like how I was engaging in repetitive movements. I've suspected the OCD from childhood, really, because I was always a perfectionist. I liked things a certain way. And I was the child who used to differ with their mother because the shoes were not in a straight line. So when I'd clean and organize, everything had to be in a straight line. Everything had to be neat boxes. And even in my thinking, everything was logical. And people had differed with me a lot because they said I was too direct. So again, in hindsight, yeah. Of course, I am triggering you today. So I got along better with boys than girls because I was more direct. I was always getting into fights. And again, I was a daydreamer. So these are some of the things we were able to reflect on, stories from my childhood, and then feeling the early childhood, adverse childhood experiences, ACEs form, to determine I also had CPTSD, childhood PTSD, post-traumatic stress disorder. And then now we finally came together and said, this is the list of things that Sharon has, I'm sharing all that in order to help people understand and to confirm what Lambert and Emma have said about the one thing that takes you to seek help, and then how they might find other things. And then just using that information to come up with individualized care. And it's the same way, I'll sneak in some nutrition. It's the same way that when someone comes in and tells me, oh yeah, my child wants to eat the same food over and over, I'm able to, as someone on the spectrum, I'm able to identify that as hyperfixation. It might be about texture. It might be about color, because for instance, a number of the autistic kids I've worked with like to eat white colored food. So it's either milk, maziwa mala, ugali, rice, and sometimes they mix them or they want them separately. They're different, kids are different. And so I tell the parent, if they've eaten that consistently for a certain period of time, you may need to introduce supplements so as to make sure they don't have micronutrient deficiencies and stuff like that. So everything is very individualized. If someone eats the same meal repetitively for 3 weeks, I'm looking to see what meal this is and whether they have all the nutrients they need, because if you're not getting any vegetables, you're likely to get constipated. If you're having trouble taking water as well, the same thing. Are you pregnant? If you're pregnant, we have to get you on supplements or on, is it Ensure? One of those supplements that you take. If they're elderly, is it Pedisure? It's all those nutrients that you may need to supplement just to make sure the micronutrient deficiencies are not missed. And I need to mention this as well, especially for nonverbal people or kids on the spectrum. Nonverbal persons are not able to advocate for themselves, so you can't tell if they're in pain. You can't tell. So there's a lot of just, as Lambert has said, listening and watching very closely to see if they take this, do they get bloated, do they get better, are they more hyperactive or less, etc. So just on and on.
Okay, so Sharon, because you're a nutritionist, what's the role of, as in, are there foods we need to eat? Just tell us about the meats and like it's me who's just in denial about the ADHD part. So just let me, for my Eshibinga people, I mean, what's the nutrition approach to ADHD, and talk down until the level of my Eshibinga people can get, and then the meats, the sea mosses, the milk thistles, what's the new one? The ashwagandhas. Are we the mukomberas? Should we take them? What should we, the do's and don'ts? Kizungu Meisha.
No, I again, ADHD, I was able to understand the question you were asking while you were asking it, because I make sense of Mashakura. So, so let me start with a hasty generalization: balanced diet, which is essentially always have all the food groups represented. You do need your carbohydrates, you do need your lean protein, and you do need your vitamins and minerals. So depending on what stage you're at in life, if you're a 7-month-old who's getting foods introduced, I would say, increase foods that have texture and of course vegetables, and you have to include protein. Just balanced meal. You may need to puree them. You may need to, it's just looking out for what this child is responding to, and a lot of it is experimenting. For younger children, as a blanket statement, let's please stop giving our kids candy so early in life. I see little babies being given juice and lollipops and sweet things, and that's when they're developing their taste buds and their preferences for food. And it is incredibly dangerous for us to do that before the age of even 3 years. Then you find kids having dental caries, you find kids having issues because they're sleeping with a bottle in the mouth. And then when the milk pools around their teeth start to go black. And yes, so feeding time is feeding time. Sleeping time is sleeping time. Let's normalize that, and let's actually give our children water if they're not at a stage where they're old enough to have their teeth brushed, so that the water washes off all that sugary stuff. Then the older they get, still, I would say postpone as far as possible introducing your kids to junk. I wish there was a way I could get parents to just have kids having junk on special occasions, as we used to do, and not as an actual food group. So because that makes especially spectrum issues a lot worse than they should be. All these artificial food colors have some effects on our gut, and all these sugars and just the caffeine that is hidden in there. If they have gluten issues, look out for bloating, look out for discomfort after eating anything with gluten. That is to say your chapati, your bread, and whatnot. If they have issues with milk, that's very common also amongst at least the ones I've heard about kids with autism. They might have gut sensitivities, or anyone on the spectrum really. So just look out for them, because it's not all of them. It's not one size fits all. And again, the older one gets, you want to look for that dream team, so that if you're eating well, but it's not, and this is the thing I wanted to tell people as well, it's you can't eat so well that you don't need 8 hours of sleep. You know, very many of us seem to separate the issues. If you want to live healthy, you have to focus on all the things that involve, what's the thing I'm trying to say? Healthy living is sleeping enough hours and taking enough water, cutting back on alcohol, cutting back on caffeine, which masks a lot of our fatigue, making sure that you exercise every single day. And let me not say exercise, you move your body every day. I work with people who have depression. You don't have the willpower to exercise on most days. So what do? I say play a song you really like in the morning and dance. Even if it's for 3 minutes, getting those dopamine hits from exercise as opposed to, a bar of chocolate is really helpful. It makes a difference in the way your brain starts to change the narrative around what makes me feel good. Get some sun. I wish I would tell Africans to take it seriously when I say get your vitamin D checks. Some people have presented with symptoms of depression, and yet you're just vitamin D deficient, because the symptoms are very similar. So if you're in one of these abroad countries, make sure you get your vitamin D supplementation during those dark months, winter. Make sure you're getting checked. If you're vegan or vegetarian, make sure you're checking your iron stores, you're checking for, and especially women of reproductive age. Very many women of reproductive age are carrying anemia from their teenage years into when they have a baby, and then, and after that. And so sometimes you present as if you have depressive symptoms, but what you actually have is anemia. And again, mimic the same thing, because you're very tired, your mood is low, you're very sad, and yet something else is going on. So Kenyans, let's normalize going for annual checkups. Check for everything. Actually save for that. Every year, tell yourself, I'm going to put aside 10,000 shillings for when AAR has that special offer for doing all the wellness checks, to make sure that, and check your blood work to make sure that there isn't something sinister going on underneath. And I think I have covered all the age groups, including the elderly in there.
Okay. Nema and Lambert, are there supplements, are there other alternative medication that, including Chinese medication and our miti dawa? Is there anything that has been proven to work, or as we say during the endometriosis discussion, the hot air?
No, actually, from my end, no, there are none. I think what Sharon has said is so true. Like I always say, diet, the therapies, and then when it's really, really stretched to the wall, then that's when medication comes in. And the medication is what Lambert was saying. But miti shamba and supplements, no, unless if Lambert knows of any. But from my end, at least the kids that I see, no, I've not come across any.
Yes, I mean, I support that 100%.
Na mkatuacha hapo tu
kabisa.
Mungu anawaona.
Tumesema ukweli.
Hi. So today you'll all stand in Trish's shoes. Trish is amazing. Kenya Power, Kenya Power, so she can't even come to the internet. But let's try and see the education piece. Saya wekelea kofia ya education tokelezea kidogo. Watu wengine, we'll just give like a general guide to education. We are not experts because our expert today is not here, but just let's try and see what we've learned from our different na nimeona Karen nuko nyuma msalimie from our different work experiences and lived experiences. What have you learned about ADHD and schooling? Sarah, let's start with you because you have taught across the ponds.
The education disparity, first of all, just the systems in the West is very different from Kenya and Africa. Every time I experience the education system in the West, I'm like, I think in Africa, the Swahili word is tulisoma kwa neema, because the way people have been lumped together within class, and there's a challenge, for instance, in most schools with a teacher-student ratio of 1 to 40 something or 1 to 50, and it's worse in some cases. If one of the students there has ADHD, it's already going to be a challenge. So already normally what happens is teachers, because you have to go through a lesson plan in the 30 or 40 minutes of class, and you have 40 human beings learning at different speeds and with different levels of distractibility, they will either tend to move at the speed of the fastest to the detriment of the slow ones, or they will move at the speed of the slowest to the detriment of the fast ones. In both cases, if you are a learner having ADHD, you are likely going to be at a disadvantage. If they're moving at the speed of the slow one, you're going to be extremely restless because you're wondering, why can't we move to the next thing? If you're the fast one, you are you're going to be humored along. You're probably going to move quickly, but I think the thing that's going to suffer is understanding and depth for you as the ADHD. So I think one long-term solution for just that is a reduction in teacher-student numbers. Will that happen soon? To be frank, I don't see it happening. Reason being, our ability to plan long-term for schools seems to be a problem. The few good schools that are there, instead of us making more good schools, we keep packing. So if we find school X is performing well, rather than replicating that and creating more schools, we just pack the same school with more students. So it's going to be a challenge. Then secondly is the misdiagnosis within the education system. So students who just like focusing on many things, and if they have hyperactivity, will be the loud ones, they'll be forever in the Newsmaker's book. It's likely they will incur some form of discipline or even be suspended. And for some of them, because they're not being properly understood, and also they are not understanding themselves well, a few, especially if you come now from super low support or where resources are limited, withdrawing from school becomes a real possibility for some of them. So I would hypothesize, I don't have data for this, but I would hypothesize that quite a number of the guys we call school dropouts were probably misdiagnosed and therefore mishandled cases of ADHD. Because even when out of school, these guys, you begin seeing them, the word that's coming in my head is in Luya, Vachetsia. They're smart, they're street smart, they're quick and stuff, but they don't want to stay in school. So that's often a second challenge. However, there's some hope that since we're moving to more of a competence-based curriculum in many places, and I'm speaking with reference to Kenya, there's hope there that a lot of the otherwise creativity and energy and opportunities for additional places to split focus will arise, so that instead of just having like the previous system where a lot of the focus was sit down, focus on the teacher, it was a very teacher focused rather than a learner focused system. The move into the new system that is A, competence based, and B, learner centered, will allow for people to identify their abilities and allow them to have more expression a bit more earlier. In the West, there's a bit more resource. I work in an office, for instance, within higher education, where part of the training we have is, detailed for ADHD or people within the spectrum, and giving them particular resources and stuff. However, I've noticed in the West is, again, depending with your background, and normally this is immigrants or minorities or first-time people, say, to reach college or high school, is just an awareness, a lack of adequate awareness or confidence to know that, hey, these resources exist, and B, that they can and should be willing and reaching out for them. So I think the people on this side of the pond, it's less a problem with awareness. It's a case of people trying to find their way in the darkness using a candlelight, when what is truly available for them is an entire system of floodlight. So this side is more battle for awareness so that they may be able to get the support. But back home on the other side of the pond, it's a question of being able to resource things a bit more differently. I hope the CBC will help redirect this thing.
So as a parent who's parented and children on both sides who've gone to education, we've done 844, we did a bit of GC, and then we've done the American system. Sometimes you sit down and weep for not just my Shibinga people, even the people who are going to my former Kawangware High School secondary. Like the differences are huge. Like the West is very far, and within the West there are also differences depending on the school districts you are in, because all the schools are funded. Huku tunaonanga kazi ya Zakayo. The schools are funded by taxpayers. And then, as Saya said, immigrants, because we have to pay black tax back home, you're not very aware of what's out there. So we end up taking our children to charter schools and some private schools, which are not usually the best sometimes for our children, but we just want them to get through and finish school. But the disparities, as in children here, even per alphabet, they have counselors. Like my children's last name is L, so they have a counselor for names starting with LU until somewhere. Yet I was asked to pay 1,500 Kenya shillings for a whole year for a student in Munjeche Primary. Sometimes you wonder when if they were children of a lesser God. But anyway, that's me just ranting away. But Nema and Lambert, Sharon, I saw your hand, but Nema and Lambert, and Nema because as a mom with a child with autism, how are you navigating the education system? Do you have these fancy things called IEPs and 504s? And we did a disabilities talk. Saya still owes us that recording, and that's when I learned that they're shadow teachers. I had never heard of that thing, but just go ahead. Yeah.
Okay, so yeah, actually, for me as a parent of a child on the spectrum, my most painful, and it's a prayer item. I don't know for how long, but it's still equal to our priority number one. It's for me, schooling has been one of the biggest battles I've had to fight for my son. I have changed so many schools. I've tried the shadow teacher. I've tried homeschooling. I've tried. I think I've tried everything. And yes, so to answer your question, so schools are vast, and when it comes to Kenya, it depends with how much money you are able to pay. I realize schools like now the high-end schools, the International School of Kenya, Brook House, Braeburn, Hillcrest, they have a very thriving special need program for children, very thriving. And when you look at what they do, I'm not sure if I can say that's maybe comparable to what you guys do, I'm not sure. But when you look at what you do, even when you talk to the consultants who go to those schools, because there are sometimes the same consultants, you consult them, but then outside, it's like night and day. And of course, it's purely because of infrastructure, it's purely because of the human resource, and of course now the ratio, because for them it's actually 1-to-1 for children who have special needs. Then now to our end, like for me, my son, I tried actually when now my son was just having the diagnosis, getting the school, I tried walking to all schools I thought was possible. And everywhere I went, they looked at him and they were like, no, we can't take him. No, we can't take him. No, we can't take him. So that's when I was given a contact to one of the most prominent consultants, educational consultant. And I remember taking my son there, spent time with her. So what she recommended was a shadow teacher. And of course, we did an IEP. So yes, we do IEP, but you see, in here, when you do IEP, especially for the learning assessment, you pay with your arm and leg. Like it's super expensive. But of course, you somehow you have to be able to do it so that you are able to know exactly the challenges that your child has and which type of learning they are going to be thriving in, and the type of schooling and the type of setup. So that kind of becomes a foundation. Then after that, we got a shadow teacher. She recommended a school. We went to that school. Unfortunately, you see now when you have a shadow teacher, you actually pay school fees and then you pay a shadow teacher. Like those are two payments. The shadow teacher, you pay her like your employer, like literally it's on a monthly basis. And then you also pay for school fees. Now, for my experience, that shadow teacher ended up being employed by the school. So I noticed that after realizing actually my son is no longer coming home with homework, and he started hating school. So one day I showed up and I was told, no, it actually came from the siblings, like teacher so and so usually comes to our class. So I was like, okay, I thought the shadow teacher is meant to be a shadow, So of course that meant the relationship ended, and then we had to try homeschooling. We did homeschooling. At first it was okay. My son really liked homeschooling, but the supervision, the level of professionalism, the level of commitment, because it's like if you don't follow up with the teacher, nothing's going to be done. So it's kind of you are actually, I felt like I was adding more load, especially because you pay for the teacher, of course, on a monthly basis, but then you also have to buy all the materials like that are needed for learning. So if now, because of the nature of my work, I was not able, because it means you have to be there, confirm, has the child learned, and whatever is written as a report, is it actually true? So we went back to school, and the school that we are in, it's good. I can give it a score of 6/10. Actually, it's the best I've found so far, and it's because their I think their ratio is at 1-to-2. And we are still learning, but yes, so every beginning of the term we have to do an IEP, and IEP is individualized educational plan for those who don't know. So you do an IEP based on the assessment of your child, where they are, and then now based on where they are, you put goals and strategies on how they are going to move from point A to point B. Then at the end of the term, again, you're called back, you do a reassessment, say what has worked, what has not worked. When you're doing IEP, it's not just educational, you also do, because my son is on the spectrum, so you also do social skills, vocational skills, activities of daily living, so that at the end of the day, he's able to, to develop holistically. Yeah. But yeah, schooling, oh my God, schooling is not easy.
And Nema, just explain what a shadow teacher is, because I'm gonna say bad words.
Okay, so a shadow teacher means it's so for a child who has learning challenges. Usually, you see, in a normal class setup, usually you have a teacher or two in front of the class. They are demonstrating a concept, and then children are expected to grasp the concept from there, and then now based on where they are, whether kindergarten or primary 1, 2, they are able to grasp the concept and put it on paper using writing and all that. Now, a shadow teacher is for children who are not able to do that. So this teacher becomes a shadow of that other teacher and of the child. So the teacher becomes a bridge between what the teacher is saying and what this child has been able to understand. And so they kind of emphasize on what the teacher is saying. So that there's that. And then the other definition of a shadow teacher is because of this system of integration, because they really, really push for integration. But you see, not all children can be integrated. So for you to make sure your child doesn't lag behind and does not stay with kids who are way younger than him or her because of the learning challenges, they sit in the same class, but then they are given their certain corner somewhere, and then they are. So this teacher is having a kind of class. They have like some session going on in the middle of that class. So that's what a shadow teacher. And so a shadow teacher is meant to be with this child everywhere they go, so that when they are playing, they are there with them. If, for example, if it's a play and it involves some social skills that this child has not grasped, this teacher is able to, teach them how to adopt into that. If they're doing some fine motor, maybe art and craft, this teacher should be there to show them how they are going to adopt into that. So basically, shadow teacher is being a shadow to this teacher and be a bridge of what is happening at a global in terms of class, and now customizing it to this child. So that's what a shadow teacher is. I hope I've been able to answer that question.
I was gonna say a nanny for the child who has education background. I was gonna say that because that's the feeling I get from the shadow teaching I've understood.
It is. It's actually true. They're like trying to synthesize whatever has been said to make it into chunks that this child can swallow. Yeah, you're so right.
Okay. Lambert, Masomo.
I'll listen to all of you, and anyone in the audience would actually feel very not disappointed, discouraged.
Mm-hmm.
I want to at least encourage everyone. I want to be the optimist in the room. And the reason is because I think we have come a long, long, long way. And we're in a space, very interesting space. I always tell people 15, 20 years ago, unge invite watu for this conversation, ungejipata uko peke yako. So kudos to all of us. Secondly, in our country, I think Saya has put it very well. The system has had challenges. There's still challenges that are there. However, there's a lot that is happening and has been happening. And I think that makes me very optimistic about the future. Hoping that things, at least even if 20 or 30% is done for starters, we will be somewhere. And that involves what is already happening. I think Post have sent you a forward that I received. I must say yesterday I was very happy to participate in an event that was focusing on really people with special needs or with disabilities. And the Ministry of Labor, the CS of Ministry of Labor graced the occasion. She was the chief guest. And actually what most of us or many did not know about is that people with disabilities are being actually mapped by the government. So if you know anyone or yourself, you feel like you have a disability, ADHD, autism, being on the spectrum, etc., they're actually mapping out and they're trying to see how then they can get to the next level and find a way of supporting these individuals. I must say that in itself is some progress. My hope is that this will not only stop at that level, but it will be scaled to the next level, waende mashinani na kila mahali, and perhaps then now we can start talking about the next step forward. So I must say, at least the government and the other whatevers are doing something. However, iko kazi mingi sana ya kufanya. And I do believe that is where the community comes in. That's where such conversations come in handy to ensure that stakeholders are involved in ensuring that this very particular important exercise is not only discussed or left at the policy level, but it is implemented. Asante sana.
Sharon, masomo, because you've straddled both ponds, right? Yes.
Yeah.
Okay.
When Saya said it is night and day, it is quite literally night and day because this is me managing a master's program without medication, and for mental health conditions, only because we have psychosocial support offered by the campus. And of course, I paid out of pocket, and that comes with some privilege that I have to acknowledge that I was able to afford it. But in all honesty, the fact that the campus even has the option that if kama ni kubaya, I have somewhere I can go, and they have all the options, including if you feel, trigger warning, suicidal, if you feel like you want to harm yourself or if you've harmed yourself, there are places, there are institutions that the psychologist gave me a link to, and she said, you can just go self-admit. You don't have to explain too much. Just show up and say, I need help. I need to be admitted. No questions asked. You're admitted, you're cared for, and it's covered by insurance. I do not know how Kenyans are surviving with the terrible economy, the floods, and everything else, because again, we are living by vibes and inshallah. But one of the things I would like to highlight is that I thrived in school when we had arts and crafts, because it was a place for me to take out, to enjoy my creative outlet. So if CBC is anything to go by, just that I'm very encouraged that it's a very handsy curriculum, and it's not just sitting and learning. At least from the little experience I got before I came here with the child I was helping care for, their homework involved a lot of arts and crafts, and it was very nostalgic for me to see them engage that way. So, and the other thing I would like to say about education and neurodivergence is neurodivergent persons are very curious and they question everything. So, and I'd like to speak to the religious people in the room. If your neurodivergent child comes to you and asks how we know that God exists, they're not trying to be irreverent. They're really just asking a question. So we need to allow for that curiosity and not assume that kids are just being rude or questioning authority because they're being difficult. Let me give an example. I have a client who has a daughter with autism, and she was sent to the kitchen by her father to take a plate after he had used it. And then when she came back to the living room, she's about 4 or 5 years old. So when she came back to the living room, her mother sent her to the kitchen, and she looked at her mother and she said, no, she, with her finger. And her mother felt very offended and told me about it during our session. And I told her, your child is not being difficult. She just didn't, in her autistic brain, she did not understand why you were sending her twice. You could have just sent her with both plates at once. And that's exactly what her husband had told her. But you know how when it's your child, you take it personally. You, as a mother, you're asking yourself, did I raise them poorly? Is this the autism or is this just bad behavior? And unfortunately in Kenya, and it's something I've mentioned in the chat with Joanne, we were beaten for everything and anything. And that was horrible for those of us who struggled to just not be too direct because there are teachers who took it as being rude. So I remember getting beaten for anything and everything, and that caused me to sort of just go quiet. and to start masking. And masking is essentially pretending to be something you're not, so as to survive your external environment. And masking has been linked to depression. So I had to pretend sometimes to be a quiet person, because if I raised my hand in class too many times, I would get into trouble. I'd be called Kimbelembele, or do I think I have all the answers, etc. And such like things. So for the educators in the room, for parents, let's be very careful about how we word things to the children in our care who may be diagnosed or undiagnosed. And the other thing is attentiveness with regard to jobs. Now, in adulthood, ADHD very often presents as the way my CV looks. I've had jobs in very many different sectors, not related to nutrition, for most of my life, my adult life. So because you go to a place, I would intentionally go to a new workplace, look for the most challenging thing I can learn there. And then once I'm done learning the hardest thing they have to teach, I'm gone. I essentially have nothing left to keep me there. I wouldn't stay for money. Again, that comes from a certain amount of privilege. I am unmarried. I have no children by choice. So I could just up and leave. So when you look at an ADHD person, especially if they don't have anything tying them down, children or a spouse or anything really, they will move from place to place. I have lived in many places. I have lived out of a backpack for a year, actually 2 years. And so when you look at us, you can see that need to just keep moving around. I currently in Germany, I have an apartment I hardly live in because I am always going to other cities. I'm very wanderlusty. I like to visit new places. If you see that, that could also be a sign. And so now imagine with regard to education, that this individual needs something that will capture their attention. And I think it's Joanne who wrote in the chat, we need very colorful infographics and stuff like that. And they make allowances for that in the education system here, so that in case there's someone undiagnosed, they can still follow with the material. And lastly, education with regard to music therapy. I think we really need to start looking at and by alternative solutions, I mean, before we decide to put a child on medication, especially, or a person on medication, how about we see if music can help, if listening to certain songs can help soothe. Listening to brown noise really helps people with ADHD. There's also white noise. It depends, because it's not one size fits all. It could be white noise, could be brown noise to help with sleeping and relaxation. But all these things do need to be included in the education system. And the last point is, and even when we say that we need to do this in the education system, let's not wait for the government to do it. Let's start at home. If you're able to, you have access to the internet, surely just Google what white noise or what brown noise is, and then figure out if that helps calm your child. Figure out, just be curious to find out and to educate yourself. There's so many ADHD awareness channels and ADHD health coaching persons on social media, because we live in an age where actual professionals like psychologists are dishing out information for free because they've realized mental health service access is limited. So let's be curious.
Because we can never stop. We have to always mention religion, Pastor Sire. I know people who join this thing get shocked at all the titles. Mhubiri wetu wa leo, Sire. Are you there?
Wapi sadaka?
Sadaka utaniona nyuma ya tent. So how do can religious leaders and our okay, I know you speak for the Christian and especially our Adventist faith, what can they do in terms of supporting treatment and not just praying about it and casting out demons?
I'll pick a line from what Lambo said about
Dr. Lambert. I know yes.
Yeah, we've known each other I'm sure even when I have a PhD, Lambo will struggle to call me Dr. Sire. So it's a big simplification. It's painting too much with one brush about casting demons and the whole characterization of Christians as just being, when it comes to these matters, as offering nothing more than prayer and good vibes. We need to remember that in most countries outside of the formal government health systems, it is often the fact that it is Christian health systems that are the biggest. The Catholic health system, for instance, I think is the second biggest health system in the world. The Adventist health system globally is the biggest Protestant health system globally. So I want to almost kupinga na kupinga kwa dhati, or just to educate guys and say, like, no, guys, Christians are very well thinking. They have a bunch of really good resources out there. So do we have characters within Christianity whose response to some of these things is only prayer and casting out demons? Yes, there are. But are they A, the majority? No. B, are they the only voices? No. Okay, so I think that context set, I can now progress to the rest. So what can Christians do as a tool, as an asset in supporting therapy? The study of scripture is actually shown to be a really good thing. Like the proper use of the Bible and, instruments like singing and depending with which religious persuasion you go, the expressions of worship, like making things, the arts, the music, the production and stuff, provide very great avenues for individuals, depending with where you are on the ADHD spectrum, to actually exercise both the energy, the creativity. Provides very legit outlets, as it were. We usually joke and say all the ADHD guys in church are somewhere in the PA room, because they're not required to sit through a service. They're always on the move. So one thing they can do is, through the various offices and departments of the church, and they provide good avenues where these individuals' various giftings and abilities can be exercised. And it's a scripture mandate that does recognize that there are different gifts and diverse ministries. So churches need to begin optimizing for the fuller expression of a wider range of abilities within its space, and also serve as a training ground where more abilities can then be trained and then deployed for deployment into the world. And by so doing, it gives ADHD guys a place to express themselves. Two is the center of the Christian ethos, in the famous words of Paul: there's now no more slave nor Jew, male or female, Greek or Scythian, but we are all one. So the acceptance message within Christianity is a good place, so that people who are neurodivergent can find within Christianity communities where they can belong. And if your church has not yet been impacted by this gospel, you can either help it to do so, or you can then look for a community where the gospel impact is already present. So that, for instance, this is not on the neurodivergence. For instance, if a church building and infrastructure is not yet disability friendly, that's something you need to bring out with your pastor and the people responsible, and say, like, hey, by the architecture of this church, you are excluding individuals on wheelchairs or people who are blind who would have wanted to come. And if a church wants to open its doors to more people, they should be able to address that. And so something similar you can be able to raise something similar and say, hey, by the way you raise your programs, or the way you guys do your lighting and your music, if it is having this kind of impact or does not think enough of these individuals. I have grown in a church that I have seen growing from a space that was exclusively optimized for neurotypical individuals. And now in many churches, we have, for instance, translation for the deaf, for those individuals who have difficulty with hearing. And I'm sure increasingly with that similar kind of ministry, more can be done. Within the Adventist fraternity, we have something called ability ministry. Initially, I think it used to be called disability ministries. And I think that's a third avenue any other community can do, where you create, what are they called? Specific departments or functions that help address pay attention to this sort of needs and begin addressing from how do we organize our service? How do we organize our space? B, how do we support the various curricula and the executors of curricula within religious curricula that we teach within the church to support individuals like this? And C, how can we provide social, spiritual support to families and individuals who may be navigating ADHD? And as a community of faith, that is encouraged to be with, in fact, commanded to be with each other. I think Christianity uniquely does that. And I think why Christianity is uniquely placed to provide this support is because of its view of humanity. In the Christian view of humanity, human beings are endowed with inherent worth because of whose they are, because they are God's people, because they are God's children. So, and you see, that is not worth that is diminished when you're either young or unborn or sickly or hyper or anything. It's worth that you have because you're made in God's image. So I think uniquely what Christianity therefore provides through its texts, through its practices, through its sacraments, through its mandate, through its gospel, is it provides those three things. It provides a community, it provides the resources, the things, the tools for cognition, and then it provides platforms where people with ADHD can be able to be adequately supported. Now, is this always achieved? No. Is this optimally used? No. And you don't therefore still judge a philosophy by its lack of optimization or by how some individuals may have abused it. And as we always, like in the US, the way they say, the work of building a perfect union is a work in progress. Similarly, the work of getting communities of faith to become the optimal spaces they can and should be is always a work in progress. But still, I still feel and believe very uniquely gifted is a Christian community to be of support to such individuals.
Okay. Lambert, I know we touched on this last week, not last week, 2 weeks ago, and we said we will at least touch on it before people go to eat. My God. Okay, one day we will do this under 1 hour. Omusara, weed, and ADHD, and any other substance that you find that people use to cope with their ADHD symptoms. But let's touch on weed specifically.
What do you want to know about weed specifically?
Tuvuta, unajua where we are, weed has been, medicinal weed has been legalized. Nikatafute.
You know,
Mm.
the question I might ask the audience, how many strains does weed have?
Indica and sativa.
Okay. Well, there are so many. You can Google. Someone can Google and you'll be surprised. Now, when it comes to the conversation of legalizing, like now you've legalized, now what is coming out very clearly, and even from research, is that one, more and more people who had never used weed who started using it are developing fast-time symptoms of mental illness much later in life. Perhaps that would mean that these people, if they had not smoked much later in their lives, would not have developed any mental health symptoms. Secondly, we are starting to, again, courtesy of research, they are starting to appreciate that, and that has always been there, that there are some people, for some reason, if they smoke weed for the first time, that becomes the beginning of the onset of psychotic features or psychotic illness. Which makes it even more interesting, because if you are 5 people here, or 4, let's say Posa, you smoke, I smoke, Saya smokes, another person smokes, like that, there's a likelihood that for me, it will stimulate me. For you, you will start hallucinating. For Saya, he might become depressed and want to go and sleep. even if it's morning there in your time zone, etc., etc. It is the only substance that sometimes, and that is THC, specifically tetrahydrocannabinoids, which is a strain in itself that might not be necessarily beneficial when it comes to medicine, the effect of medication, but instead people use it out here for various reasons, then you find that it's only drug that has different effects on different people. So the long and short of it, jijue. And if you are ADHD, there are some people who've reported for sure that when they smoke marijuana, they are able to, the marijuana is able to manage the symptoms of ADHD. And that sometimes, that conversation reminds me of my very old grandfather many, many years ago, who would go to the shamba and smoke weed very early in the morning, and that would make them work throughout the day. I'm sure we all can relate with that story of having grandfathers who would smoke weed, and without it, they could not work. So it brings also the other aspect. Marijuana for medical purposes, marijuana and the effects that it has on people's functioning, like I mentioned, whether to legalize it or legalize it here in other parts of the world with the kind of information that or research that's coming out, it's a story then that has to be discussed very carefully. And if need be, to in terms of implementation, we have to be extreme.
Okay.
We have learned from other places. Yeah.
The questions in my head are over. Yes, Sharon, go ahead.
So I'd actually just wanted to back up what Lambert had said, because I went down a rabbit hole of researching on ADHD and weed. And then there's a particular doctor on Instagram, I think it's Dr. Okoja, who talked about the link between smoking weed, especially in early years before your brain is completely properly developed. You know, all those who start smoking as teenagers. WHO says your brain is fully developed at what age? Is it 25 or 26? So yeah, basically that's being very dangerous. There are other ways to consume it. So whether it's like your weed cookies, etc. And as Lambert has said, it's ujijue. For some of us, just having a small amount of it has been able to help with sleep. And especially because I've had chronic insomnia since I was a teenager. And it's the only thing that has worked consistently because melatonin stopped working at some point. And it's something I have, from the research I've been doing lately with Black immigrants, it's the only way that very many of them are able to cope outside of alcohol. And by cope, I mean coping with very hard labor, because a number of us come here and do hard labor jobs, whether it's in construction or working at warehouses where you're lifting very heavy things, and you're doing it all night and you have to be in class the next day. So it's sort of a coping strategy. And then, yeah, so those are some of the concerns I thought I should highlight. I don't know if there's anything else I've left out, but yeah.
Okay, because we need to eat. Mambo matatu. Let's Dr. Nema, are you still there?
Yes, I'm here. I'm just learning a lot. Thank you. This was such an insightful session.
Asante. I can take Sifa. Okay, but yeah, go mambo matatu. Tufunge kituo mambo matatu. What are your mambo matatu? What should we take home? Because we are closing the chapter on ADHD until kitu ingine itokeleze.
Okay, I think for me, the first thing is anytime you see a child behaving in what should otherwise not considered to be normal, quote unquote, it is always nice to seek professional help or professional opinion before you make your own conclusions. That's the first thing. And that's not only at home, also in schools. So whenever you see your child behaving and everyone is commenting, it's just nice to go ask your doctor, okay, I've noticed 1, 2, 3, what do you think? That's the first thing. And then my second is when something is not working, just don't force it in your child. if your child cannot wake up in the morning or your child cannot sit still, maybe it's because they actually can't, not that they are disobedient. Hitting and calling names and getting frustrated may not really take you anywhere. And then my third take home is please just like visit your therapist. Actually, I think I've self-diagnosed ADD on myself. I don't know if I can face a therapist to confirm it. But I think it's nice that we are able to make use of the therapists around us so that we are able to really function in our most optimal states. Because I think ADHD is so common, more than actually that I never thought. It's very, very common. Yeah.
Sharon, mambo matatu.
So if I were to summarize, I had written it down as a PSA, public service announcement to Kenyans. Let us kindly refrain from voicing our opinions on the following 3 things. Actually, I'll make it 4. People's bodies and their appearances. We don't know what people are going through and what we are dealing with. I feel like our community is very, very big on victim blaming and body shaming. We are still very fat phobic, very opinionated. This is essentially the internet being an evil place, but hey, Kenyans, we need to calm down and find ways to compliment people outside of their physical appearances. You don't know what someone is dealing with. And especially with children, as I learn more about disordered eating and how many kids' issues start when people start commenting about their bodies, that becomes a very sensitive issue for me. Also, let's be very cautious about how we voice our food, our opinions on people's food choices and eating habits. Again, you do not know what someone is dealing with. So if you don't have anything nice to say, just don't say anything. And then, and also let's be very cautious about talking about people's children in general, how they choose to raise them, how their children look, and especially for kids, for parents who have kids with disabilities or any intellectual or physical challenges, just leaving the house to face the world is hard. Waking up every day is hard. So let's be very sensitive. Let's teach our children not to stare or make, insensitive comments, because people out here are struggling. Let's share a little more kindness. Yeah.
Lambo.
Mambo matatu.
Yes.
Jambo la kwanza.
Mm-hmm.
When I say that, Google that, for example, when I said, how many strains are there of marijuana? The reason is that for sure, all of you are very knowledgeable. We live in a set where we have so much information, too much information, which sadly sometimes becomes stressful. And this is the first point I'm trying to make, that with all the knowledge we have, let us take time, like Neema said, to use this knowledge, try and seek support to make a sense of the knowledge we have gathered. Because sometimes we get ourselves in a rabbit hole, and this can make matters worse. Number 2, and this point supports the first point, is after the knowledge, the next thing is to start thinking of how we can work together, all stakeholders, including the government, the county government, people in the private sector, the community. How do we come together to implement some of these things we are talking about? I think that's the elephant in the room, because we have talked, and everybody knows that if we continue talking, the cows will not only come home, but they will sleep, and the following day will wake up, and with time tutakuwa tumewakamua na hatakuwa na chochote ya kutoa. So I think it is high time, and this is my last point, for us to implement strategies of implementing, because the only way this will happen is if we speak the same language together. Hayo ndio maoni yangu, mambo matatu. Asante sana.
Hallelujah. So for the audience members, does anyone have a question we've not answered? You can raise your hand and we'll allow you to speak. Otherwise, we will give Saya the opportunity to close the mkutano. Going once, going twice, sold. Okay. Saya.
Okay, so thanks everyone. I hope I hope part of the panel has been able to pay attention for the 2 hours. And collectively it's going to be 4 hours plus the previous session. But thank you to our doctors, Nema, and to Lambo for making time and sharing your expertise on 2 different occasions on this important thing. Thank you, Sharon, for bringing in the food angle and your own experience. Totally appreciated as much. I want to trust that as a result of this, none of us will needlessly struggle or see other people struggle with this issue while they can be pointed in the direction of help and hope. I would encourage us to realize that in a real sense, this disability is not a inability, but it's just ability repurposed in a totally different way. And so I trust and hope that we will be able to discover what that entails and make the most of it. Once again, thank you for being part of this video during its shooting and its subsequent watching. Thank you for those who will share, and thank you for those who will even go ahead and comment. It is because of you that we get the mojo to always keep coming back and doing this. We encourage you to keep liking, sharing, subscribing, following. And we also like you to hear from you. We want to know what topics you want addressed, what speakers you'd like to be brought. The places you can reach us are on Facebook. We are Authentic Dialogues with Sarah Jackson. On YouTube, it's the same. There's Authentic Dialogues and there's Sarah Jackson. Those are 2 separate channels. Then there's one Sarah Jackson on Instagram. Your thoughts and views are totally appreciated. Paul, thank you for facilitating, and thank you for all of those who've been supporting in the background. So until next time, I want to wish you all the very best and see you next time.
I'm going to stop the live for like 2 minutes, and then in case you have a question you want to ask that you don't want to make it to the interwebs, this is the opportunity we give people to ask. Otherwise, if there are no questions, we will just end it.